Hello there everyone, this is Kamran Popal and I'm back again with the ST3 urology interview preparation. Today we're going to go over some questions about incontinence and this is a stress incontinence scenario. You can have a look at the history which I've done in a separate video previously. I'm just going to go on answering some questions and some things that are asked. They can ask about examination, or if they ask for assessment, if they said how would you assess the patient, usually you go on telling the history then examination. If they say tell us just what will you ask in the history, then you just tell the history. I didn't tell about the examination in my history video, so you'll say in the presence of a chaperone I will proceed with the examination looking at the patient's BMI, palpable bladder or any loin tenderness. On PV and speculum exam, because this is a female station, so stress incontinence, lady leakage on cuffing, 3 children, etc, etc. So on PV and speculum examination with chaperone, I will look for any leak on cuffing or urethral prolapse, estrogen status or atrophic vaginitis, then cystocele or urethral diverticulum or rectocele, and I would also check the pelvic floor muscle strength using the Oxford grading scale. If you say something like this Oxford grading scale, they sort of know that you've done some incontinence clinic, so you know these grading scales and how you check the pelvic floor muscles, because everyone's going to say this leak on cuffing, estrogen status, cystocele, but if you say specific scales, it's quite good. They will not go into the Oxford grading, but just for you to know, Oxford grading for the pelvic score is between 0 and 5. So 0 is no contraction, 1 is a flicker, 2 is weak, 3 is moderate with lift, 4 is a good lift, and 6 is strong with lift. After that, they may ask you about the investigations that you would perform. So, an ICIQ questionnaire and a bladder diary, urine dip, MSU, microscopy culture and sensitivity, flow test and post-ward residual, and urodynamics can be used as a second line. And then other tests can be tailored according to the patients. Actually, some consultants who work within the incontinence clinic are wanting to hear this. So pad testing, there's 2 types of pad testing. There's a 1-hour ward test or a 24-hour home test. So 1-hour ward test is basically if you've got greater than 1.4 grams of weight of the pad in 1 hour, then that is significant. And if you've got a greater than 8 gram pad in 24 hours as a home test, then that is significant. A home test is more accurate, so if you want to say 1 test, then you can say a home test greater than 8 grams, which will be significant, and it acts as a good screening tool for incontinence. And you may consider an ultrasound, KUB, and flexible cystoscopy if there's any red flags present. You can mention that towards the end. So management of stress incontinence. So you've got conservative, medical, and surgical management. Conservative management is lifestyle advice, weight loss, modifying fluid intake, and smoking cessation. Number 2, pelvic floor exercises with pelvic floor physiotherapist with 50 to 70% success. In some books, it is mentioned that you can use continence pessaries as well. Actually, one of the Bowes guidelines actually mentions this as one of the conservative measures. Then you've got medical management for stress incontinence, which is topical estrogen if there's atrophic vaginitis. Duloxetine, now it's got a 50% success rate, but it causes cognitive issues. So it's not always used, but you can say this is one of the options which can be considered. The way it works is that this is SNRI, serotonin reuptake inhibitor, and this increases the urethral tone via the pudendal nerve. But obviously, as I said, it can cause memory issues, so it's not always used. Now, surgical treatment options, always mention surgical treatment options. You should always be discussed in a pelvic floor MDT and with the consultant prior to being offered. And the surgical management is number 1, occlusive agents, which is bulking agents such as bulkamide injection. Another one, artificial urinary sphincter, but it's usually done in men and usually done post-radical prostatectomy as the commonest cause of incontinence. So if it's a female scenario, you might not want to mention it. Then moving on to supportive, which includes mid-urethral sling, which can be synthetic or autologous. We've got TVT or TVTO, but they're not routinely used in the NHS because of dyspareunia, etc. And NICE do not allow it except for research purposes, whereas autologous slings are routinely used in the NHS as supportive mayas, and they both have 80 to 90% success rates. Colpus suspension is also one of the surgical management uncommon approaches in complex cases. As a last resort can be an SPC or urinary diversion surgery. So this is your conservative medical and surgical management for stress incontinence. Then they can ask for how you would consent for urethral bulking. You can have a look on the BAUS PDF leaflets. And yeah, that's about it. As far as you know some basics, the side effects of the medications that you're going to prescribe, like duloxetine, and you understand the basics of surgical management. You're appropriately escalating it, so discussion in the pelvic floor MDT consultant before actually jumping on to telling occlusive agents this, because this is you're never going to make this decision. It's usually going to be a pelvic floor clinic or a functional clinic with a consultant present who's going to make decisions for different surgical management. So this is sort of the station of stress incontinence and the questions that they can ask. I wish you all the best and hope you can all get a national training number, and I will see you next time.